Good morning, everyone, joining us from different places, different areas in Canada, and good evening to everyone in India. Thank you for joining us today for this session on the updates on the Canada-India Spinal Cord Injuries Innovation Award. We have a compact program today with 5 presentations from the teams. Without any further ado, I would like to welcome our first speaker, Dr. Nemi Vanthia, CEO and Scientific Director of ISIC Impacts, to give a few words of welcome. Dr. Vanthia.
Thank you very much, Feria, and good morning, ladies and gentlemen. Good evening to our friends in India. On behalf of ISIC Impacts, I'm so delighted and honored to welcome you to this session on Canada-India Spinal Cord Injuries Innovation Award. We have had a wonderful teams working with us, and I know I was there last time at the Indian Spinal Injury Center, Harvinder, where we very gracefully hosted us. And I remember listening to all of the wonderful presentations there, I think, and there was a tremendous amount of progress being made in these projects. So it's such an honor to, be part of this endeavor between Praxis, Spinal Injury Center, and ISIC Impacts. And thanks to Praxis, first and foremost, for giving us the opportunity and introducing us to Indian Spinal Injury Center as well. So we're thankful to you, Bill, I think, for the opportunity ISIC Impacts has been given. And also thanks to Harvinder for really providing us this wonderful platform to work in the Canada-India corridor and make, maybe an amazing, contributions, in fact, to the entire discipline of spinal injuries research. So I'll stop here. Thank you again, and I look forward to the exciting presentations. Thank you.
Thank you, Dr. Vanthia. Next, we have Dr. Bill Barbrell, CEO of Praxis Spinal Cord Institute.
Thank you, Peria, and good morning, good evening. It's great to see some familiar faces again, and it was wonderful to attend your event yesterday, Dr. Vanthia and Peria. I really appreciate the invitation. It's my pleasure to welcome you all today to hear these new updates on these Innovation Award recipients. And, I think most of you are aware that our role as Praxis, and Praxis, Greek word, which means moving knowledge into action, is to help lead global collaboration in spinal cord injury research, innovation, and care. And we try to do that through accelerating the translation of discoveries and best practices into improved quality of life. And I really feel that these projects are very consistent with that, with our vision, which is a world without paralysis after spinal cord injury. And so we do this by trying to provide resources, infrastructure, and knowledge to make a life-changing impact on the health outcomes. Convening people, engaging people with SCI along the way is really part of the core values that we try to follow, and they help us set priorities in research and innovation and the commercialization program. Because if the idea isn't going to be utilized by someone with a spinal cord injury, then what's the point of pursuing that? It must reflect the needs of the people who actually have the spinal cord injury. So back in December of 2018, correct me if I'm wrong, Emmy, but that was really when we began through with the collaboration with you and with Harvinder and the India Spinal Injury Center. I recall we announced the winners of the Canada-India Spinal Cord Injuries Innovation Award, and that, of course, was based on peer reviews. The 5 projects emerged from that competition, and I'm really delighted that even with all of the challenges with COVID, the projects have completed significant milestones. So these 5 promising projects have the potential to really make a difference, and that's what we're really aiming to do. So we'll hear. I won't recount all of the projects, but we'll hear from them today, and we're quite excited about that. And I understand that will include Dr. Chabra, who will discuss the development of the wearable artificial muscle for the tetraplegic hand. So we really see ourselves as part of an international community, and through competitions like this one, we can help transform the future of SCI care. Along these lines, and I thought I would make mention of as well a new program, because I think it may be of interest to some of our attendees today, is that we're looking for new ways to develop commercializable ideas. And this year, in collaboration with the University of Toronto, we established an ideation clinic and launched the Praxis Ideation Challenge. This is a 6-month staged design challenge, and the first of its kind, at least in Canada, in our country. And the initiative features an active learning curriculum, live pitches, mentorship, financial awards, and prototyping support. There were over 70 participants from across Canada and 5 terrific demonstrations that demonstrated ideas, started ideas really, that will be soon showcased. In fact, I think that's next week. The Ideation Challenge fits perfectly within the ecosystem, we feel, of innovation, which we're trying to promote. And so I really wanted to share that with you, because if there are any people associated with institutions here today interested in learning more, I would invite you to reach out to our Director of Commercialization, Rushi Reina, and I'd certainly be happy to provide contact information. And I would really like to say again, express our sincere thanks to IC Impacts, the fantastic team that you have there, and Dr. Chabra and his center and his wonderful team. We can't imagine having better international partners. And we look back very fondly on the visits we've made there, and the people that we have met, and the culture that you've created there is really quite extraordinary in our experience internationally. And so we're delighted and very privileged to have you both as partners. And I'd also just finally like to recognize our funders at Praxis, which include the Western Economic Diversification through the Government of Canada and the province of British Columbia. So, we have a fantastic program ahead. So I'll now turn things over to Dr. Chabra. Thank you.
Thank you, Bill. Thank you, Professor Nami Bhantia and Bill, for the kind words that you have mentioned. It is all teamwork, and teamwork becomes especially important when we are working in a field like spinal injuries. So we know that nothing can be achieved in the field of spinal injury management without an interdisciplinary team management. And the same would hold true for advocacy in the field of spinal injuries. This becomes especially true when you are dealing with spinal injuries in emerging countries like India, where there are huge challenges. I'm sure there would be challenges in developed countries as well, but the nature of the challenges would differ there. But I think it is a great initiative to be able to collaborate together with IC Impacts and Praxis for this innovation and research award in the field of treatment and care of people living with spinal cord injuries. This would be the start of building bridges between the Indian and the Canadian researchers, such that they can come out with newer products, and not only come out with newer products, so that, as Bill mentioned, these unique and commercializable technologies get available into the market for the sake of the quality of lives of people with spinal cord injuries. So we have only to thank Praxis and IC Impacts for this wonderful initiative. And I'm sure the expected outcomes that have been thought about from this initiative would be delivered. And with time, our collaboration should get stronger and the scope should increase. and we should be able to involve more and more researchers in this field. Thank you once again for this wonderful collaboration.
Very good.
Thank you. Thank you very much, Dr. Chabra. Our first presentation is by Dr. Nishu Tyagi from the Indian Spinal Injury Center on the project titled COPE, Community Health Outcomes and Personalized Education Exercise for Spinal Cord Injured Individuals. Dr. Tyagi, if you could please share your screen for the presentation.
Yes, thank you. Hello, everyone.
Nishu, kindly unmute yourself. Got muted.
Yes, sir. I'm just opening my presentation. Can you see my screen, please?
Yes, we can.
Okay. So, hello, everyone. Myself, Nishu from Indian Spinal Injury Center. I would like to share the updates on Project COPE, which is entitled as Community Health Outcomes and Personalized Education Exercise for Spinal Cord Injured Individuals.
Dr. Tyagi, you may want to put it on presentation mode. There's just button at the bottom. Yeah, that'd be wonderful.
Okay. Thank you. So these are my team members from India and Canada. I would like to acknowledge all the members who really helped in executing this project. As you all know, if you see India, there are a lot of challenges that SCI individuals face because of illiteracy and inadequate patient education, and there are a lot of financial barriers that usually patients face. If you see the Canada, there are similar challenges, not very similar, but yes, there are challenges related to affordability and accessibility, especially in rural participants. While taking care of these challenges, the goals of COPE project is to improve the community health outcomes by developing user-friendly web portal for SCI individuals and caregivers, to provide community guidance support where there is none, and improves the quality of care where there is some, to encourage independence and good practices among SCI individuals and caregivers living at home and community. These are our action plan that we made during the project. Phase 1 is questionnaire assessment to identify the priorities of individuals. Phase 2 is development and validation of training materials. Phase 3, knowledge translation. Phase 4 is transfer of technology. During the questionnaire phase, we did this just to estimate the level of knowledge and awareness exist among the caregivers and SCI individuals, and rehab professionals about the technique of community inclusions, identify the lacunae and important topics on which people with SCI require information, and identify the priorities and treatment preferences among SCI individuals. These are the standardized questionnaires which were shared by Canadian team to identify the functional priorities among the individuals. We did the survey among the participants. It was 353 participants that we recruited from India. And we make such cards to avoid the biasness from the individuals so that they can easily understand and could relate what is their main priorities. This is how the patient is just taking out the priorities as per like 10, 9, 8, and accordingly we rate the individual's priorities. Then these are the feedback on novel technologies to share the information among patients. This is the similar, the 5 indicates the most interested and 1 indicate the less interested. Then this is the questionnaire which was designed to identify the service need among individuals. This is related from occupation to ADL through assistive technology and ADL activities. So we identify the top 10 major priorities among SCI individual in India, which was related to routine SCI test timelines, bladder exercise regimes, spasticity related problems, married opportunities, sexual health related concerns, wheelchair service guidance, government employment schemes, disability certificate, which is really important in India to get the benefits in employment and other facilities from Indian government. Then dress outfit concerned by females. The most important considerations that we take care in the development of project is that we find the content specification, then development of content, production and population, and accordingly review and revision. These are our broad features of proposed web portal in which demographic data can be stored. Training videos, animated images, and still images are also there. Customized home programs, exercise videos using the common home equipments, age and injury level based, because we would like to make the customized programs, and especially the FITT rule that we provided in this web portal, which is frequency, intensity, time, and type of exercise that the patient has to do. Self-management programs, special section on pediatric, women and geriatric SCI, separate blog, networking for professional and patients, language in Hindi and English. This is the first draft of main domains that we identify with the help of experts. First is environment related information, second exercise, policy, health, and finally the caregiver. We conducted the luncheon workshop in ISIC, in which we invited many societies representatives, and we validated these domains for the web portal. These are the sub-themes in which we get the suggestions from the team to modify and correct the information which has been identified. So for example, if you can see, there is a bathroom modification in which suggestion was there to combine the bathroom and home modification as a single sub-theme, and it should be separate for tetraplegics and paraplegics. So these are the similar sub-themes which was identified, and accordingly we did the correction which was suggested by every expert. This is an exercise related information. Then suggestion was to remove the electrical stimulation guidance because it could harm the patient and himself. Then the policy related information, the suggestion was to include the education section separately, and advised to add the vocational training along with the link of organization who could provide such facilities for the same. Then again, in health related information, there was suggestion to add the information related to urology, skincare, bladder management, and age related complications. In caregiver training module, there was a suggestion to add self-help groups, so it will be easy for the patients to get connected among the peer group members, and information on coping strategies and caregiver burnout. So I would like to give you the brief overview of the videos. Our team have drafted more than 250 videos. Apart from 250 real videos, we have 21 animated videos. So because there are a lot of modules in which we cannot make the real videos. So this is the example of the recreational video, because it is really important that the patient could understand what they can do. So like she is doing certain designing activities which we call Mehendi in India, which is really very famous. So this is the certain of very short recreational programs that we designed for every spinal cord injury patient so that they can take up. And so there are a lot of recreational programs apart from this. This is just an example I'm showing because I cannot put 250 videos in the PPT. Then again, this is like how you can transport, you can use the transport, public transport for the patient. What could be the real technique so that patient can avoid the mistakes. So we took the help from the experts to identify the correct technique. So this is the videos that will be uploaded on the web portal. So this is our web portal, www.scicommunityhealth.com. So in November, the web portal will be live. And if you see, this is in the Hindi language, and there will be a subtitles in English. And I will show you, if I can show you later, the yoga video. So the advantages and benefits of this project, it has a potential to broaden the reach of personalized care in the community and even in remote areas. It may also help in creation of a follow-up and community data repository. We are in talking with our web portal team who is developing our web portal. So we are trying that if every patient will access the web portal, then we can have an access of all the records, whoever patient is visiting our web portal. So there is a proper demographic details which will be embedded in this web portal. The scope project may cut the cost of avoidable secondary complications and admission solely for the rehabilitation purposes. These are future direction, the way forward. The conversion of portal into other spoken languages to broaden the reach of portal, commercialization process that we would like to really understand about this project. Then translation of knowledge and training to Indian community, for example, cardiopulmonary training resources in other 22 spoken languages of India. Then collaboration with other countries, and it is really good that I would like to share with you that one colleague from South Africa, they're really interested in the scope project and they would like to execute the same project in South Africa. So this is the thank you. If I have a 1 minute, I can show you the yoga video. Can I show the yoga video?
Yes, you have 1 minute. You can.
Thank you. Okay. So these are certain videos that we have uploaded on YouTube for our experts so that they can see if the video is okay. Can you see? Okay. So she is doing the yoga.
We're still,
which,
sorry to interrupt. We are still looking at the last slide of your presentation. We can't see the video.
Okay, I'm sorry. Can you see?
No, you may need to stop sharing, and then when you reshare, you can select the screen you want us to see.
Okay. Thank you. Okay. Can you see now?
Yes.
Okay. So these are the videos that we have uploaded on YouTube because it will be easy for our experts to rate the video, and accordingly we can help in revising. So if you can see the subtitle, she's the normal person who is doing, and this is the spinal cord injured individual who is doing. So accordingly, the person, this is the modified yoga, and this is the normal person who is doing the yoga. So she's a paraplegic. So you can see the audio will be in the Hindi and there will be a subtitles which will be coming like this. Thank you.
Very interesting. Thank you very much, Dr. Tyagi. I believe we have a couple of minutes for questions. Does anybody from the audience have any questions for Ms. Tyagi?
Hi, I can ask a question if there aren't any others, but I'm happy to wait as well.
Hi, Aaron. Sure. Yes, please go ahead.
Yeah, so this is really great work and actually would have been very useful when I started my project, and I'm definitely going to check this out to learn more. So congrats on your work. I was wondering if somebody has like more videos, can they contribute them to your site as well as other training programs? Or is it like a centralized system where it like kind of all goes through you?
So you are asking about if we can add certain other videos in this, something
Yeah.
like that?
Yeah, like if people have
Okay.
other ideas of other interesting, I don't know, challenges in occupational therapy for people with spinal cord injury, for instance. Yeah.
Yes. So if I give you the answer, if I understand correctly, see, this is a very big project. We have
Yeah.
just made 250 videos. There is always a scope to widen the web
Yeah.
portal. And there is also a thing when we are having a conversation with our team, the web developer, he was saying that if we'll upload more videos, the portal will be heavy. So we have to take care about that thing as well. So we are in the process. This is just the first draft, the web portal that we have, developed. Yes, there are more opportunities that we can work on. So maybe you can share and we can see what we can work on next.
Thank you.
Thank you. Thank you, Dr. Tyagi. Our next presenter is Mr. Aaron Yurkovich for the project Designed to Impact, Uniting Researchers, Makers, and Spinal Cord Injury Survivors Through Open Source Technology. Aaron, the floor is yours.
All right, thank you. I'll share my screen. How is this?
Good, good.
This is good. Okay. And okay, perfect. Yeah, so thank you for joining into this presentation today, and thank you for inviting me to be part of this really amazing initiative. I feel like this initiative really needed to be there in order for this project to progress as well as it has. So this was work in collaboration with IC Impacts, the University of Toronto, and then Makers Making Change, as well as many others you'll see as we go through the project. So yeah, so the title is Designed to Impact, Uniting Researchers, Makers, Spinal Cord Injury Survivors Through Open Source Technology. I'm Aaron Yurkovich. I graduated my PhD last year, and I'm now a postdoctoral fellow at Imperial College London. Since this, I've started 2 companies. One, I'm CEO of Wearability, where we focus on technologies for rehabilitation for clinicians and for patients. And then the second is a research arm where I'm director of engineering. This is human robotics. And today I'd like to talk about participatory design and how this is used in neural engineering and how this has been implemented through the IC Impacts project, really focusing on inclusive development, usability testing, and evaluating at scale. So the first really where my project began was with volunteering in stroke rehabilitation clinics, where it was very important to get this ability to, move people's arms and hands, see where the struggles are in different mobility impairments, and really see what the workflows are with therapists and patients to understand their needs. And I think that actually as an engineer, this is something that we rarely get access to. So I think it really changed the way that I looked at my project. So one of the needs that I discovered that really there wasn't that much work on back when I started my PhD was that actually 1/3 of stroke patients are not able to use their hand in an effective way, making certain bimanual tasks very difficult to do, such as something as simple as grabbing a water bottle so you can open the bottle, or holding your toothbrush so that you can apply toothpaste to it. And this has some significant barriers that are related to rehabilitation and access to assistive technology that really could help these people recover, whether it's acute or chronic stroke or spinal cord injury. And then as a result, there's these large deteriorations of quality of life that I think that we can really make a huge impact on. And so what was interesting here is that when I started my project, the academic direction was so different than what we found users really were interested in. As opposed to having a high number of degrees of freedom and many different types of motion, people just wanted something that worked and that could help them perform things in their daily life. For instance, we didn't need that it had to be fast and powerful, but actually making it slow and comfortable was actually a more important aspect here. So when I started this project, we started very simply with things that you could make at home, you could make within a couple minutes, and you could apply to somebody in a safe manner. And through this, we learned what the actual needs were. So this kind of innovative prototyping very early on with patients and with their therapists. And so this is where we came to IC Impacts, was with a device that provided extension and flexion of the hand. Yet you could see that it was very early stage system, and we really needed to make something that was more user-friendly and scalable. So this came to evaluating functional prototypes throughout the design process. So the first one here, the Hero Glove provided extension of 3 fingers. And we found very, very quickly that this increased range of motion and performance on the tasks that we performed. So this was very exciting because we found that this soft approach was a lot more comfortable, that we found that there were certain actuators that worked better than others. And this device we were able to give to clinics in order to perform a lot of tasks in the clinic that these patients generally would be isolated from doing and then not have that much ability to participate in rehab. And then the thing that we learned here was that actually it's also important to increase grip strength, not just the hand extension itself. And this was because even if people have grip strength, sometimes it becomes very fatiguing or increases the amount of tone in their arm and hand, making their posture not as comfortable as it would be otherwise. So then from here, we added some tendons onto the front side of the glove, and these helped substantially in helping people do precise motions, such as holding a pen and writing a note to a loved one. And then also we found that this increased the range of motion because we weren't just extending, but also providing the grip. The last thing here that was important was that we actually we learned that motivating users to use their hand or having some way that we could detect their intent made a big difference in how engaged they were using this device. It's not just opening and closing the hand for you, but it's a part of your body in a sense. So then here was the next approach to using this glove in a closed loop way that made people have to try to move their hand, and then we could detect it through these electromyography muscle signals, muscle activity signals, and this would control the glove to open and close. So the remarkable finding here was that even if people have no motion to extend or flex their hand, we can still see the EMG signals. And these EMG signals could then be used to control the device, allowing you to try to open and close, and the glove would follow your thoughts. Skipping here to some of the other tasks. So we found that just having the hand open initially made it easier to get around certain daily objects like picking up a phone, and then more comfortable to hold the phone on your ear as you go about daily life. I'm going to skip through these just because we only have 10 minutes today. And so another one, this was the guy who couldn't hold his toothbrush, and here with the glove, he's able to do so. I think what was also interesting with bringing this device to the clinic and having so many people use it is we found that people have very different abilities in their shoulder and their elbow and their trunk control as well. So it was very, very interesting to see how we could use this technology with other technologies that support those parts of their body. And so here you can see giving yourself the ability to cut your own food. Say you're going to a restaurant and you want to, be able to participate in these without asking for support. And then I thought what was very interesting was that the portability of the system allowed us to do tasks that weren't just sitting tasks like these, but also going towards standing tasks. So something that you would do either, when you get in and out of the shower or when you're going to walk your dog. These are things that would make it very useful to have something that's a portable system, wireless, untethered. So we did a lot of work on making it compact and lightweight for this aspect. So then huge thanks to Makers Making Change, the India Spinal Cord Injuries Center, and then CN, a clinic in Madrid, Spain, that have really, their therapist and stroke patient teams and spinal cord injury teams have allowed us to get a lot of feedback as we bring this device, roll it out to homes, to clinics, and then seeing how it actually interacts in these therapy clinics. So within the technology, so we're looking at technology adoption. One of these is in the home. What was interesting is when we brought it to the home, the types of standardized assessments we were doing before, actually they didn't encompass all of the tasks that people really care about. So these were not things that we had tested in the lab, but it was interesting that it still worked for those kind of aspects. One being stabilizing something on your lap when you're driving around your wheelchair with your sometimes less affected hand, gripping other sizes of bottles, doing your exercises because you can now hold a bag and do your bicep curls, and then combing your hair and opening these bags that are hard for any of us to open as well. One of the big challenges here was actually in making this device something that we could either collect data frequently or following up with our users of the device. And this is a big next challenge for us going forward. Once you bring the device home, it's very hard to know what somebody is doing with it. And lastly, just down at the bottom here, Makers Making Change made a fabulous make your own Hero Glove user manual. So anybody can make this device, and then we're always here to train and support as people go through that development process. Then we've collaborated with therapy clinics and therapy students, and these students have helped us to see how the Hero Glove could be integrated into therapies, as opposed to enforcing a certain type of therapy just based on the device itself. So looking how the device can be incorporated into constraint-induced movement therapy, motor imagery, strength training, and especially task-specific therapy, where it just goes directly into independence. And so here is a video from how we use the device in the spinal cord injury clinic in India. And so at ISIC. And so here we have a patient who's learning to use the glove for the first time. And the point here was to assess how well the device works and how easy it is to control. And so what really motivated us from here was how we can have people take the device home and use it in the clinic as well, and see if this always available assistance can really improve function and use of your system throughout your day. So then from here, we're now working as well with a clinic in Madrid who's using the device with a lot of their clients as they just come through the therapy process. And we realized that actually by making this device accessible to people, which is really through IC Impacts, they can now take it off the shelf and use it with a patient as that patient needs it. So just for interest of time, I'll skip to some of the results, which are very interesting, but still very preliminary. And that's that from baseline to even just a week later, we already start to see improvement in function and improvement in their actual goals that they stated at the start of the therapy. So here we're going to see if the clinical measures that the therapist uses on their own, as opposed to ones that we enforce for research, we can still measure performance gains just through this, through the scales that they use themselves. And then lastly, I'd just like to thank all the clinicians and patients that have let us trial out our system as we go about all of these different changes. So here they find technologies in their clinic to use the glove with, and then can analyze how different control strategies improve the recovery. So here is just another interesting one. So this is somebody with spinal cord injury who we got to extend the device to. And so here, learning to perform tasks again, like writing, as well as here you can see they have 2 gloves on to support each of the hands as they go about something like picking up an object or taking an object out that's very tight and hard to use. And then lastly, the devices now, we have 50 of them throughout the world, a lot in Canada and the States, as well as now in India, UK, and Spain as well. And really trying to support people that are home users, rehab clinics, and university research as well. So with that, we've implemented this FASTER methodology, and through this FASTER methodology, we're trying to improve the way we do iterative design and prototyping, and then make these devices accessible to people. With that, I'd just like to thank everybody who's been part of this. It takes more than a village in order to make one of these technologies make it to market. And thank you so much, IC Impacts, for really kickstarting this process.
Thank you very much, Aaron. That was a very interesting presentation. Thank you for that. Do we have any questions for Aaron?
So, Aaron, if I could ask a very brief question. So what are the power requirements for this hand?
Yeah, so we use a 9-volt battery that you would get from your smoke detector.
I see.
And the reason for this was that it was something that people are comfortable with, and we weren't worried about people taking it on a plane or people taking it to different locations. But we really do want to make this like a, a plug and play device in the future that you recharge just like your phone.
Right. And when you talked about data collection, so this is internet enabled, the hand itself?
So we have an app, but we haven't been able to get research ethics to do that kind of data collection. So I think that actually is like a very tough aspect of the kind of restrictions we have in research that aren't always there in commercial technologies, just to get, be able to film or being able to collect the amount of usage from the device. And now we're starting to find that if we do something locked like an SD card, and then we come to the person's house and take the SD card later, that's sometimes accepted. But the internet approach is very hard to get through. Yeah,
I understand. That was my second question, but yeah, thanks for answering that. This would be many, other regulatory issues there, but thank you.
There's so many regulatory issues that really not, getting to go through the process has really helped me learn, what's accessible and why it's accessible and why it costs as much as it does.
Wonderful. Excellent work.
Thank you.
And I remember trying it. I have tried this myself, actually. So
okay.
It's wonderful. Yes.
Thank you.
Yeah.
Aaron, it's Bill Bearable. Sorry, Feria.
Hello.
Hi, it's Bill. Aaron, great presentation. I really enjoyed that.
Thank you.
What would you say is the biggest obstacle you're going to need to overcome? What's your biggest problem in making this available to many?
Yeah, so right now, to be completely fair, we need to raise about $200,000 to $300,000 in order to make a facility where we can manufacture the device in like a very standardized and regulatory approach certified way. So that's actually the interesting challenge of going from this iterative design approach to kind of like that rigid structured manufacturing approach. And the reason is really that there are a lot of financial needs in order to make something open source still accessible, as we know, even with the Neurosquire Society program. So transitioning to this like clinical product approach is very beneficial in that the way of making it more accessible, but also increases the cost of your technology once you go through the regulation process.
Great. And that $200,000 to $300,000, you're talking about a North American currency there. How long would that last you? Where would it take you?
So that would take, so that would take us to have this design with some small modifications for waterproofing and electrical safety, that it's certified, and then we can sell it or have it available to clinics that would purchase it, and then they would be able to train patients to use the device and allow them to bring it home. As far as making it something that people can just buy off the shelf at a Shoppers or something, it's a little bit more regulatory needs that we'd need to go through after that stage. Yeah.
And what kind of expertise do you need now that you don't currently have?
Probably the regulatory side, the law side, as well as, even just having people with spinal cord injuries test out new versions of it, and having some clinical supports that are like some therapists actually on your team to, make the right kind of evidence-based, determination of what people, how people should use the device in the clinic. Currently, it's like an exploratory approach for therapists, but some do really want a regimented program as well. Yeah.
And you're familiar with our Incubate program?
Yeah, so I just applied to the most recent one of the recent funding calls. So we'll see.
Okay, thanks very much. Thank you, Perry.
Thank you.
Thank you, Aaron. Our next presentation is a project by Dr. Hossein Rouhani from the University of Alberta on wearable technology to monitor sitting posture and reduce the pressure injury risk. We have Kanglin Zink, who is going to be presenting for us today. Great. Kanglin, I think you're muted.
Oh, hello everyone. Can you hear me?
Okay, perfect.
Okay,
Please go
okay,
ahead.
good. Okay. So I can start. Hello everyone. Good morning and good evening. My name is Hansen Xing, and I'm a postdoc researcher in neuromuscle control biomechanics laboratory. And today I will work as a representative of Professor Hossein Rouhani to present our research work, wearable technology to monitor sitting posture and reduce the pressure injury risk. Oh, it's a moment. Okay. Damage to any part of the spinal cord or nerves at the end of the spinal canal often cause permanent change in stress, sensation, and other body functions below the site of the injury. People with SCI often rely upon wheelchair propulsion as their primary means of independent mobility. However, according to the literature, 1/3 of the persons with SCI are reported to have pressure ulcers. Owing to sitting in a wheelchair for a long time, blood supply to the skin could be decreased, and over time it can cause the skin to break down and form an open sore. Therefore, it's meaningful to research how to prevent the pressure ulcers in people with SCI. In clinic, pressure mapping system is generally used to measure the sitting posture distribution, and then precise statistical parameters of pressure distribution and center of pressure can be acquired. By referencing those information, the suitable sitting posture or relevant adjustment could be found. However, the high price of the commercial pressure mat limits its wide application in our daily life. In addition, the sitting pressure distribution is usually changed with the sitting posture. Therefore, to understand the sitting pressure distribution, the evaluation of the sitting posture is also highly needed. To realize this goal, we are aiming to develop a real-time, daily use sitting posture monitoring system for sitting pressure prediction. To achieve that goal, wearable technology into IMU sensors will be used to measure the sitting posture, and the machine learning method will be used to predict the sitting pressure distribution. And then the developed system can provide feedback information, the maximum mean pressure or center of pressure or maximum sitting pressure positions to persons with spinal cord injury to reduce the risk of the pressure ulcers. Put it in detail, the hardware IMU sensors and the pressure mat will be used to record the sitting posture and the sitting pressure distribution. Using the proposed signal synchronization method, the raw data will be processed at the time same level. And then using the algorithm developed for the IMU signal processing in NCBL lab, the sitting posture angles can be calculated. Considering the differences of the sitting posture measured from different participants, the normalization of the pressure mapping result has also been done. And after that, using those inputs, the machine learning method, BP neural networks has been developed for the sitting posture prediction. And then for the performance evaluation, a better BP neural network setup could be found. And finally, for application, using IMU measured signals will be processed by the machine learning method, and we can get the sitting pressure related parameter prediction result. As one of the key technology in our research, how to measure the sitting posture is the first question to be answered. Herein, the sitting posture was defined as the sit and phi, which stand for the sitting angles around the left, right, and front and back direction. Using the two IMU sensors installed on the chest and the pelvis of the participant, the acquired IMU signals will be processed as a following step. After the main processing of the functional calibration and IMU coordinates frame correction, the aimed sitting posture angle can be calculated. As for the second main step in our research, the machine learning method, for inputs for the BP neural network, and each parameter such as the maximum maximum pressure, mean pressure, central pressure in x direction, central pressure in y direction, or maximum pressure position in x direction, maximum position in y direction, is the output of the model. The three layers network was developed. We use the same setup for the development of BP neural network, and finally, six BP model were generated. Finally, the evaluation parameters such as the mean absolute error, coefficients, or correlation were used to evaluate the performance of BP neural networks. The experimental method was used to establish the database for the machine learning method development. For this experiment, 31 sitting postures were measured by the IMU sensor installed on the chest and the pelvis of the participants. To improve the precision in raw data acquisition, a non-continuous data acquisition method was used. Owing to the effect from the COVID-19, it was difficult to recruit the participants. Therefore, currently, we only recruit 10 participants for the experiment. And the age, the weight, and the height distribution were shown in this table. Using the acquired database, we use the leave one out cross-validation method to check the performance of BP neural network. The mean of all trials, the statistical results are shown in the following tables. We can find that a better prediction result could be acquired from the mean sitting pressure distribution. However, for the maximum pressure, the absolute error was around 5 mmHg, and the absolute differences, which is less than 4 mmHg, account for 55%. Therefore, the proposed BP neural network can predict the mean of the pressure very well. As for the prediction of the center of the pressure, the mean absolute error of central pressure in x and y direction is less than 1 inch, which is less than the resolution of the experimental used pressure met. When it comes to the center of pressure distribution pattern, we can find that the COP pattern will mostly keep by the prediction values. Whereas for the prediction of the maximum pressure distribution, the performance of BP neural network is not that good. The mean absolute error was around 3 inches in x and y direction, and the maximum pressure position cannot be well predicted. This may be caused by the abnormal changes exist in the same sitting postures, which are get by raw data. Therefore, the optimization of the BP neural network is greatly needed here. To successfully apply the developed technology, we also developed a low-cost sitting posture measurement and processing platform. Bluetooth and Wi-Fi-based IMU sensor has been developed. It is cheap and affordable, and it can work for 12 hours at a sampling rate of 3 Hz. Combining with those low-cost IMU sensors, a Raspberry Pi-based sitting posture monitoring system has also been developed. The total price of this system is only $240 CD, and it has a capability in 3 channels IMU sensor data processing. According to this project, we have the following outcome. Firstly, a sitting posture monitoring system. Secondly, series of data processing methods, which include sitting posture measurement method, normalization method for pressure mapping results, BP neural network for sitting pressure distribution, a prediction. Thirdly, the low-cost hardware for sitting posture monitoring system. Next step, the optimization of the current plan will be continued. Hopefully, this technology can be implemented in the spinal cord injury hospitals in Canada and India. And then we will do the technology transfer and the commercialization work. Finally, take this opportunity, we really appreciate the support from IC Impact, Indian Spinal Cord Center, and Praxis Spinal Cord Institute. In addition, we express a deep thanks to all team members who contribute to our project. In the end, welcome for your comment and suggestion. Thank you.
Thank you very much for that interesting presentation, Kangling. Do we have any questions for Dr. Zhang? Okay, I have one quick question. You were mentioning about the sensors that the people with the injuries are wearing right now for the angle measurements. Is that just for this stage, or later on they would also have to be wearing those sensors?
Actually, for the application of technology, 2 IMU sensor will be needed to install on the participant's body.
Okay.
If this is needed for the future application.
Okay, I see. Thank you. Do we have any? Yes, Bill, please go ahead.
Yes, thank you, Kanglin. Very interesting presentation. Congratulations on the work that you're doing. A huge problem that needs to be solved, pressure injuries. And I don't need to tell anybody on this call that. So similar to my questions of Aaron, what are the biggest hurdles you're facing now? The resources, expertise, whatever. What's your biggest problem, and what do you need to get over that next hurdle, that next valley of death, as we call it in commercialization?
I would say that currently, owing to the COVID thing, we didn't get enough participants, and hopefully, we hope in next semester we can get more participants and we get more data. And the second thing is for the machine learning method, as I showed in the presentation, for the maximum sitting pressure position prediction. Still, the neural network didn't perform very well. So we will work a lot on this and try to improve the prediction result. So this is the main challenges we face. Thank you, Bill.
What do you need to overcome that? Do you need more money? Do you need different expertise? Do you need just time? What do you need?
We need more experiment participant.
Okay.
I thought, yes. And for the budget, I would say more money would be better. Maybe, but my professor knows exactly. Yes.
Okay, thank you for sharing that. We have on this call, I believe our Director of Research, Vanessa Noonan, is on, as is Pamela Berg, and she has a team of people with lived experience, and at least one of our commercialization team is online as well. So, you know, if you have specific problems and you need some advice, we're available.
Okay, thank you.
Thank you, Bill. Sorry that I have unstable internet connection, and Kanglin is kindly presenting the vote instead of me. I mentioned if you can have more participants, which we're not able to have during the time, that would be great. We could have richer data sets for training our machine learning algorithms. The project is finished for us, but I guess we need to find a way to continue the experiments.
Thank you, Dr. Rouhani. If there are no other questions, we can go to our next presentation. Next, we have a presentation by Dr. Harvinder Chopra from the Indian Spinal Injury Center on the development of wearable artificial muscle for a tetraplegic hand. Dr. Chopra.
Thank you, Feria. Can you see my screen?
Yes, we can.
Right. So I would want to start by thanking Praxis and IC Impacts for giving us the opportunity to work on this project. I'd also want to acknowledge my co-investigator, Professor Sitikanta Roy, and especially the team members, Dr. Shakti Goel, Mr. Aniket and Mr. Aditya, and Nishu. They are there in this meeting today, and they have done the bulk of the work. I'm just their face and presenting on their behalf. You need no introduction on what a catastrophic event is spinal injury. And that loss of hand function is a particularly devastating aspect. And Aaron talked about this also previously. So in order to work on improving hand function and quality of life, a lot of work went into studying hand biomechanics and finger actuations. So we decided to work on this project to develop the wearable artificial muscle for a tetraplegic hand and to determine whether this developed device would improve hand strength, task performance, and independence in performing daily activities. The phase 1 was doing a literature review, phase 2, design phase and iterations, phase 3, fabrication of the device, phase 4, development of controlling system, and phase 5 was assembly and clinical testing. So we started, this is the rough sketch and design to validate the idea of tendon routing and internal expansion of soft pneumatic actuators. And our first prototype was based on this ring-like structure. You can see this prototype here, and we discontinued this later for comfort reasons. After brainstorming, we came to the conclusion that a 3D printed fishbone-like structure could bring required flexibility similar to the human fingers. And this was the basis for our prototype 2. Soft pneumatic actuators were fabricated using liquid silicone and developed in a way such that it could bend in the forward direction at a particular air pressure maintained by battery-operated mini pump. You can see here the actuation of a pneumatic actuator with fishbone-like structure and how it could be placed on the hand. And we developed 2 finger-based artificial muscle gloves combining the concepts of fishbone structure and pneumatic actuation. This is a palmar view for that, and this is a dorsal view of it. So the components included a control system, which is a control box designed to in-house the electronic components like microcontrollers to operate the wearable artificial muscle glove. Arduino Uno to control the buttons and pneumatic valve. And the solenoid valve was used to control and channelize the airflow to maintain the required air pressure. Battery-operated mini pump to generate the air pressure required for pneumatic actuation. And a linear actuator was used for actuating artificial tendons. So the movements which are achievable in fingers and thumb with the artificial muscle were flexion and extension only, which would help in grasping, especially spherical, cylindrical, and power grasping function. And to provide dexterity to the movement, soft pneumatic actuators as well as linear actuators were embedded in the glove to provide the movement. And the glove for each hand is different. For the clinical testing, we went through the required regulatory approvals from the IRB and the ISIC. And we also registered it with the Clinical Trial Registry of India. So we had an informed consent form. And we used the SHAP kit, which is a Southampton hand assessment procedure, which is a clinically validated hand function test used to assess the effectiveness of upper limb. It is made up of 6 abstract objects and 14 ADLs. A definite process is there to use it. And each task is self-timed, and the functional score is based on the task completion time relative to a normal population. The overall score is out of 100 for the normal population. Scores below 95 imply impairment. So we had definite inclusion and exclusion criteria with low cervical spinal cord injured individuals. So from C5 to C8, AIS A, B, or C, 18 years and older being involved in the study, especially those having sustained an SCI for preceding 6 months. And those with comorbidities or previous trauma or surgery or contractures they were excluded. So 10 subjects were enrolled for the pilot study to assess the effectiveness, and they performed 3 grips with variations of light and heavy objects. They would pick up a spherical, power, and cylindrical grasp. The time was recorded by the assessor with while the subjects performed tasks barehanded as well as with wearable artificial muscle hand glove. These timings provided inputs for the development of the functionality profile, and SHAP score was generated. So you can see the pics here of the type of grasp with and without gloves. And this will give you an idea of how it works when they try to do it without the glove. And when they try to do it with the glove. So SHAP scores were generated, and we also took subject feedback on the gloves, and most of them were quite satisfied with the glove. The SHAP score of the subjects using artificial muscle glove was higher than that of subjects without using artificial muscle gloves. Of course, there are limitations of the study and our glove, which is in the process of evolution. The size of the glove is a bit large. It lacks artificial intelligence, and patient needs to click the button for movement. It can only provide grasping movement at present, and that too palmar grasp. Thus, the wearable artificial muscle is based on the principle of pneumatic actuation and could prove to be an effective alternate in assisting the persons with spinal cord injury and peripheral nerve injuries for grasping function and better inclusion in the community. Of course, it has limitations, but it has also pros in that it could be marketed at a very reasonable cost where people could afford it. And with time, this price should go down. We would continue with the clinical validation. We would try to reduce the weight and dimensions of prototype 3 and try to optimize the soft pneumatic actuator so that it can deliver more force and less air pressure, and check the force generated at the fingertip when pneumatic and tendon actuation is active simultaneously by using the load cell to get the data from the load cell and analyze it for the optimization of the controller. 3D printed linear actuator mounts with slide and lock mechanism is something we can also work on. We could make the controller box a more portable and with inbuilt power source. And we could employ moment arm pulleys to drive the tendon laterally and achieve a simultaneous execution of abduction and flexion motion. Of course, we can also go in for modeling and analysis of the actuation mechanism and make it a closed loop system by adding some feedback element. Of course, the ultimate aim would be to work on the commercialization of the end product. I thank you for your patience and would want to acknowledge once again the work of the team and thank IC Impacts and Praxis for giving us the opportunity to work on this project.
Thank you very much, Dr. Chhabra. Do we have any questions from the audience for Dr. Chhabra? Yes.
I'll ask a question if.
Sorry.
Yes.
Yeah, go ahead, Aaron. Go ahead.
Yeah, I thought this was amazing, and when we started, we had we were wondering, should we go the soft approach or the DC motor approach? So I love to see that, yeah, both are still being extended. I was wondering, so because you have this pneumatic power source, are there other applications if somebody then has this this pneumatic source, say, strapped to their wheelchair or something? So in addition to moving the hand, are there other use cases where having pneumatics is useful on a wheelchair?
I think definitely, Shakti, would you agree with that?
Sir, that's a wonderful question, Aaron. So we have been working with IIT Delhi with Dr. Sitikanta Roy, and he has been very active in this soft muscles. And one of the applications that he has been trying is using these for soldiers for strengthening of the Achilles muscles, especially for the soldiers who are working in Siachen at the glacier peaks. So he has been using it very, that's a defense funded project in which the lab is developing these muscles to strengthen the Achilles tendon so that the soldiers can walk in the snow. And other applications, I think we'll be exploring with time once we finalize this product.
And then just maybe a follow-up related to the control. So I even find with our electromyography system, we have, half the people like the electromyography and half of them really like the robustness of the button. Do you find that you're still getting the push to go beyond the button control, or do you think that that is what people want?
Absolutely. So our focus from the very beginning has been to develop a low-cost device. Yeah. We have been working with a number of institutes and trying to collaborate to link it with brain-machine interface, let it be EEG or something like MRI. But our motto has always been to develop a low-cost device which can reach the masses, especially the spinal cord injured in Indian population, right? So that has been focused from very beginning. And we definitely plan to explore it further and incorporate BMI. But this would be one of the products that should come into the market so that the people who cannot afford the high-cost device can get into the community.
Thank you.
Yeah, to add to that, what Shakti said, Aaron, we mentioned that this would be within our future scope. And of course, India is a diverse population, right? The rich here are richer than the richest anywhere. And that population of the rich would be more than the population of most countries anywhere in the world, right? So we have to work on that end as well. We would want to have an entire spectrum. And we mentioned that we would want to work in this regard, right?
Thank you.
Yeah, Bill, you had a question?
Yes, I really enjoyed your presentation. Arvinder was very clear. And, it's actually a very complex piece of machinery, in my view. You've got lots of challenges, no question. Not to get too granular, but I was curious, the sound that came through on the video, was that the pneumatic device? And I guess my question is, in recognizing you've got to strike this balance of cost and functionality, which is not an easy walk to make. Is there any potential for electrification of it, an electric motor rather than pneumatic device? And also, if you have what you need in terms of expertise to try and miniaturize some of these things to make it smaller, and if not, we also have, as Nemi is very familiar, a Quantum Matter Institute at UBC, who are working with some of the folks in SCI as well.
Yeah, we mentioned that is within the future scope. This is just a prototype that we'll work upon further. This is a concept that we have worked upon. Aditya and Aniket, would you want to take that question?
Yes, sir. Thank you for handing over to me, sir. Answering the question, actually, we have replaced the pump that is already in the prototype. We have replaced it with a new pump that is a inbuilt rechargeable pump, and it produces very less noise. Even you cannot identify it. So we have already replaced it, sir.
That's great.
So the other part of the question, Aniket, was whether rather than a pneumatic actuator, we would look at other options.
Definitely, sir. So using pneumatic actuator was one of the primary things for Dr. Sitikanta Roy, because it provides the fine motion, and with using the hard motors and actuators, the motor cannot be that fine. Motor activity cannot be that fine. So that's why we went for the pneumatic actuators.
But we would, Bill, the idea is that we have to promote collaboration, and we would love to have inputs and support from all of you to improve this device, because this has a great potential, because if we can have it at a really affordable price within the Indian subcontinent and also globally, it will add a lot of value, right? Vanessa, you had a question there?
Yeah, thank you, Dr. Chhabra. It's wonderful to see the technology and very exciting. And my question was, it was very interesting to see the changes that the patients had in terms of function. Do you see also for that this could be used in rehabilitation? So if a patient has some residual muscle functioning, that they could strengthen those muscles as part of their rehabilitation, or do you see it more as an assistive device when they move to the community, or both?
No, I will take that question first on part of the team. Definitely, right? It should definitely help in strengthening muscle power because it could be a form of exercise. You're very right on that. Shakti, would you want to add to that, or would you differ in this?
No, so I totally agree with what has been said. Though we started it with the aim that we'll try and we'll include the people in the community by using this device. But when we tried and used it on the patients, when we did the pilot study, we realized that this could be used for rehabilitation purposes also. So that will also be one of our eventual goals.
Great, thank you.
Yeah, Himani.
I'll just say good luck. I think this is a wonderful device. If you can make that available, this would be a huge assist, and I mean that in every respect. Hi, Shakti and Eket. Nice to see. Nice to hear you again.
Bill, we have the advantage, in working with the Indian Institute of Technology, the alma mater for NEMI also and many others, right? So we, and IIT being close by, right, we have actually the possibility of having all stakeholders involved in taking our initiatives forward. So that is the beauty of it. And I would only want to thank IC Impacts and Bill Bearable and Praxis, right? So to help us strengthen these initiatives, you are aware that we also came out with low-cost motorized wheelchair, thanks to our American collaboration. And this also, we are in the process of getting it marketed through the Indian government at a very cheaper rate than what it is available in the market right now. So thank you. Thank you.
Thank you very much. Do we have a question from Himani? I see a raised hand.
I was just wondering that if this is working on the distal part, what if the patient is having a C5, C6 injury and he is not able to have the deltoid, or he is not able to move his proximal part? So it will be difficult for those. I'm not sure. So my question is it difficult for the patient to use this for the distal part when they don't have the proximal strength? Because up to my clinical expertise in this spinal cord injury patient, I always feel that proximal imbalance is always is always an obstacle for distal recovery. So what are your thoughts on that?
The principles for management would remain the same, right? So you can use it only where people have proximal good power, but of course, we can find out ways and means to stabilize the proximal part also so that they can use it for some function. And we have been doing it, but only thing right now is those are a bit cumbersome devices. But of course, with time, they will evolve and we should be able to have them work further, right?
Yeah, thanks.
So you are very right, right? You need to have a good proximal power to be able to use it in the distal muscles, right?
Yeah, thanks.
Thank you. Okay, I think we have a couple of minutes left for a discussion on the topic of where do we go from here, seeing all the presentations, the devices, the patient tests and everything. Where do we go from here and what would be the next phase of this program? I leave that open. Maybe Bill, Dr. Chabra, Dr. Bhatia, you would like to make comments on this?
Yeah, I think one of the most important things is, like most research, right? We should not let this end here till it reaches the market. And I think you are well aware that most of the research doesn't reach into the market. So we are aware about your initiatives in this regard, but I think we should closely monitor and ensure that the end objective of the collaboration is achieved. I would want to take inputs from Nemi and Bill on how we could do that, right? But I think that is very important.
I couldn't agree more. And I think we don't want to lose the momentum. You know, there's been some great work done here. And so I think, I don't know if we have all the answers on the call right now, but certainly I think just to have these updates first and foremost is a way to help to maintain that, because you're all moving quickly and learning as you go. And I think obviously, or at least some of the obvious needs would be, you know, the financial resources and the expertise that's necessary to solve the problems that you've encountered and the ones you will continue to encounter along the way. And so I think, you know, that's where our research and our commercialization team can provide some advice. And we do have some programs that the innovators can apply to that exist already, but there may be other opportunities that exist to go to, you know, early stage funds that may exist in India and Canada to help resource the next step. I mean, there's clearly a very good understanding of the problems of spinal cord injury. We can help to provide people with lived experience, you know, to try these things, as can you, Dr. Chabra. I mean, you have a world leading facility in this respect. So I think it's really a matter of identifying what the next set of problems are and putting our heads together and trying to introduce these leaders, these innovators, to people who can help them in their journey. And I'm not the one who can identify, you know, where the early stage venture angel investment can come from in India, but I know there's an awful lot of it.
Agree with you, Bill. I think there are plenty of opportunities with the Government of India, Department of Biotechnology and others, where with this initial prototype, we can work to improve upon it further and make it a better product for commercialization. So totally agree with you. I think there are enough opportunities that we need to tap upon. Nemi was wanting to say something.
Yeah, I think it's, looking at the progress these 5 projects have made, I'm absolutely blown away, I think, here in terms of what has been accomplished in spite of the pandemic. And I'm really, really impressed with the outputs here. It's exciting, and really congratulations to all of the teams, I think, and really having done just a wonderful and fabulous job here. And I would echo exactly what Bill, you and Harvinder said. We need to start really looking at what the next phase is, absolutely. And I see that in sort of 2 terms. One is, I think I'd like to open this up a little bit to other expertise that exists in other domains. You know, we do close, you know, passive monitoring, active monitoring in many, many other areas. And although it's not so much applied to the health field, but we do it in many other disciplines where there is, you know, this closed loop, you know, active efforts, I think, to sort of, you know, take sensor data back into actual actuation, or, you know, other types of interfaces that could be developed. And I'm just wondering, I've seen some wonderful work being done in Japan as well on essentially the same areas. But I mean, the question is, you know, to the teams here, I think, how could we actually expand this particular effort, I think, to bring some more international experts to work with us, and maybe start off with the wonderful workshop, I think, where we can, you know, go beyond Praxis and IC Impacts, and I think involve maybe other, you know, bodies around the world, I think, to really provide that additional feedback where we are not we're able to actually go to the most optimal, most elegant solution, I think, to the problems we'll be dealing with. So that's one. The second one is, I think, going forward, I see lots and lots of opportunities for the next phase here, and funding, regulatory support in countries, demonstration projects in First Nations, for example. I think we have certainly done through IC Impacts a lot of related work, I think, with in these sort of three areas. And I think we should really start now discussing amongst ourselves and have a brainstorming session as to where we go from here in terms of really the next phase, commercialization, working with different companies, bringing additional support. There is the Gates Foundation that is constantly, I think, we've been, talking to them as well, I think, in terms of really the support that we could get. They've been more on vaccination efforts right now, but I think there's definitely an opportunity with a number of other agencies, and this could be quite substantial funding. Much way beyond, I think, what we have currently at the moment. So I think let's put our minds together, I think, to both in terms of really expanding the expertise group here and bringing some other experts from around the world to super refine our systems, come up with more elegant solutions, and also, I think, look for the next phase through additional funding from other sources.
Very well said, Dr. Banthia, and I couldn't agree more. So we'd be delighted to participate in that kind of an effort.
Wonderful. Okay, do we have any questions from the audience or our presenters? Any last minute questions, any ideas you'd like to share?
So I was going to say, should we maybe organize another longer brainstorming session, I think, amongst ourselves? And with Harvinder and Bill's permission, I'd say maybe IC Impacts could sort of proceed with maybe a second series of these, discussions.
Definitely.
Okay.
And also collaboration amongst the various researchers, how to take inputs on whatever are the products, how to improve upon them. So I think it would be a very worthwhile exercise.
Yeah. Wonderful.
Definitely. Wonderful. We will be following up with that. Okay, I would like to thank everybody, all our presenters, Dr. Barable, Dr. Chabra, Dr. Banthia, thank you. I am recording the session and we'll be uploading it on our YouTube channel. I can share the link with everyone afterwards. Yes, with that, I just want to thank you. Have a good night, Dr. Chabra, and a wonderful rest of the day and a wonderful weekend to everyone.
Thank you. Thank you, everybody, and have a wonderful evening and a great day to our colleagues here. Thank you. Bye-bye.
Thank you.
Thank you
Bye-bye.
so much.
Stay well, everyone.
Yes, you too.